By the end of this presentation, I hope you'll be able to describe the proper administration technique for otic formulations and understand the mechanism of action, common side effects, dosing strategy, and patient education points for the following condition: otitis externa, otitis media, and cerumen impaction. First, let's begin with the basics of otic preparations.
The ear is divided into three regions. The external ear is composed of the pinna, ear canal, and tympanic membrane. The inner ear consists of three small bones with Latin names that roughly translates to the hammer, anvil, and stirrup. The middle ear is connected to the pharynx through the eustachian tube, which equilibrates air pressure across the tympanic membrane. The inner ear has two regions: the cochlea, which is responsible for hearing, and the vestibule, which is responsible for balance. Today's presentation will focus on conditions that affect the external and middle ear. Patients should be taught to properly administer otic medications since only about 40% of patients medicate appropriately. The proper instructions for otic preparations are listed here. Patients should also be instructed to minimize trauma to and avoid water exposure in the ear while an active infection is going on. When there is marked ear canal edema, a wick of compressed cellulose or ribbon gauze may be placed in the canal to facilitate otic administration. Wick placement permits eardrops to reach portions of the external auditory canal that are inaccessible because of canal swelling. As the canal responds to treatment and patency returns to the ear canal, the wick often falls out. When a parent or a caregiver has to administer eardrops to a child, it's important to have the child lay flat with the affected ear facing up on a pillow or stuffed animal. For the caregiver or parent to pull the ear backward and down to open the ear canal, and then to place the correct number of drops in the ear and continue the administration as appropriate. As a pharmacist, I often get asked whether or not ophthalmic preparations can be used in the ear or otic preparations can be used in the eye. What do you guys think? Which one's true and which one's false? Ophthalmic preparations have a neutral pH and therefore may be better tolerated than otic preparations, and therefore ophthalmic preparations can be used in the ear. However, otic preparations cannot be used in the eye due to the concern for pH, clarity, and etc. that's needed in eye drops. The first disease state we'll talk about today is otitis externa. Otitis externa is an acute, painful, inflammatory condition of the external canal that may extend from the pinna to the tympanic membrane. The rapid onset of ear canal inflammation leads to ear pain, itching, discharge, and canal edema and redness. Tenderness with movement of the tragus or pinna is a classic finding. Most common cases are from swimming or minor damage from inappropriate cleaning. Otitis externa can occur at any age and is the most common cause of doctor visits for ear pain. The infection can spread into surrounding soft tissue and bone if left untreated in some patients. Necrotizing otitis externa is a medical emergency that occurs more frequently in older adults with diabetes or immunocompromised patients. Otitis externa is caused by the breakdown of the protective epithelium barrier by abrasion, maceration, or fluid introduction. The two most common isolates are Pseudomonas and Staphylococcus species. However, about 1/3 of the cases are polymicrobial. Fungal pathogens, such as Candida and Aspergillus species, are common in tropical environments or in patients previously treated with antibiotics. Inflammatory skin conditions and allergic reactions can cause non-infectious otitis externa and can be chronic. Topical antimicrobials, including acetic acid, aminoglycosides, polymyxin B, and quinolones, are the treatment of choice for uncomplicated cases. Some formulations will also have corticosteroids, which may help resolve symptoms faster. However, there is little to no evidence suggesting one product is superior to another. Neomycin, polymyxin B, and hydrocortisone formulations are reasonable first-line therapy if the tympanic membrane is intact due to the effectiveness and low cost. Ofloxacin and ciprofloxacin dexamethasone can be used if the tympanic membrane is not intact or if it cannot be visualized, since they are approved for middle ear use. Oral antibiotics are reserved for infections that have spread beyond the ear canal or in rapidly progressing infections. Pain is a common symptom of otitis externa and can be very bothersome. Oral analgesics are the preferred treatment, including NSAIDs and Tylenol, depending on the patient. Benzocaine topical ear drops may decrease the effectiveness of the antibiotic and therefore should be avoided.
There are several ways to prevent otitis externa. For those that are worried about swimmer's ear specifically, there are isopropyl ear drops. 1 to 2 drops of rubbing alcohol can also be used. A mixture of 1 to 1 isopropyl alcohol to white vinegar and earplugs are all strategies used to prevent otitis externa, specifically in relation to preventing water from getting inside the ear canal and to aid in the drying of the water that may be in the ear canal. Now let's move on to otitis media. Otitis media is the acute onset of middle ear inflammation with symptoms very similar to otitis externa. It's common in children, with 80% of children having at least one episode of acute otitis media and 80 to 90% having at least one episode of otitis media with effusion before school age. Acute otitis media is usually a complication of a eustachian tube dysfunction following an acute upper respiratory infection caused by a virus. Infectious acute otitis media can be caused by bacteria in about 50 to 90% of the cases. Streptococcus pneumoniae, H. flu, and Moraxia catarrhalis are the most common organisms. Analgesics are recommended in all patients complaining of ear pain, fever, or irritability. Disrupted sleep is the most common symptom of why parents seek care. Therefore, analgesia around bedtime becomes particularly important. Ibuprofen is preferred since it has a less frequent dosing interval and is less likely to be toxic than acetaminophen. Reminder that ibuprofen can only be used over the counter for patients that are 6 months or older. The typical dose in pediatrics is 10 mg per kg every 6 to 8 hours with a max dose of 40 mg per kg per day. Topical benzocaine may also be helpful, which is a contrast to otitis externa. Antibiotics should be routinely prescribed for children with acute otitis media and severe symptoms, and for children that are less than 2 years old with bilateral otitis media. Severe symptoms include moderate or severe ear pain for at least 48 hours, or a temperature of 102.2 or higher. For other cases, observation before prescribing antibiotics is appropriate. A large prospective study found that 2 out of 3 children will recover without antibiotics. If observation is chosen, there must be a plan for the parents to follow up in 48 to 72 hours for persistent symptoms. This plan could be a scheduled follow-up visit or a backup antibiotic prescription to be filled only if symptoms persist. Persistent symptoms for 48 to 72 hours after treatment requires a repeat ear exam. If otitis media is present, you can initiate or change antibiotic therapy. If symptoms persist despite appropriate antibiotic therapy, consider intramuscular ceftriaxone, clindamycin, or trypanocentesis. As you can see here, amoxicillin or augmentin are the preferred agents in otitis media. The most common side effects of these antibiotics include GI upset with nausea, vomiting, and diarrhea. Giving or taking the antibiotic with food may decrease the amount of GI upset, and it's important to educate the patients to complete the full course of antibiotics. It is important to note that otitis media with effusion does not warrant antibiotic use, as they do not hasten the clearance of middle ear fluid. The last condition we'll be talking about today is cerumen impaction.
Cerumen is a mixture of fatty secretions of the sebaceous and sweat glands with dead skin and other debris. Typically, these secretions are propelled by jaw movement of the canal to the opening where they dry up and flake off. Earwax that sits in the canal for an extended period of time or picks up excess debris will become dry and hard and can cause a blockage. Cerumen impaction is present in about 10% of children, 5% of normal healthy adults, and up to 57% of older adults in nursing homes. Increased incidence occurs in those with an anatomic deformity, those with an increased number of hairs in the external auditory canal, or those with a physical barrier in the ear canal, such as a cotton swab, hearing aid, or earplug. Treatment options include watchful waiting, manual removal, the use of a cerumen or irrigation. Referral to a specialist for further evaluation is indicated if treatment with a cerumen agent followed by irrigation is ineffective, if manual removal is not possible, if the patient develops severe pain or has vertigo during irrigation, or if hearing loss is still present after cerumen has been removed. The use of cotton swabs and ear candles should be avoided. There are 3 types of cerumen softening preparations: water-based, oil-based, and non-water, non-oil-based. Water-based and non-water, non-oil-based agents increase cerumen miscibility, whereas oil-based preparations lubricate the wax. All of these agents should not be used in patients with tympanic membrane perforation. Once the cerumen is softened, the ear canal can be irrigated with warm water or saline if the patient still has symptoms. Sometimes the cerumen may cause the earwax to soften and be able to propel itself along the ear canal. In conclusion, proper administration of otic preparations is key for medication effectiveness. Otitis externa and otitis media have different treatment routes, and cerumen can help with cerumen removal. If you'd like more information about the things talked about in today's presentation, please see these resources. Thank you for listening, and I hope you learned a little bit about otic pharmacotherapy.